thank you very much for inviting me here today. Thank you, Anne-Marie, and thank you for that excellent start, Anne-Marie. I think that's really got us kind of going for where we want to go. And these kind of events just obviously meant we have to have one boring academic who comes along and does the research and science and all the really dull stuff. And that is my job, and I'll try and do it as well as I can. I'll just tell you a little bit about myself and what I do, and then I'll go on to tell you a bit about some of the challenges of what we mean by evidence. I work in 4 different places, so I'm a professor of criminology at the University of Derby in England. I'm honorary adjunct professor of addiction science at Monash University in Melbourne. I'm honorary professor of research and global governance at the Australian National University, and I'm the president of the Recovery Outcomes Institute. But what's relevant to my talk today is that I've collected, over the course of the last 10 or 15 years, between 2,500 and 3,000 recovery stories. And they really will inform what I'm going to talk about today. And if you go back about 5 or 10 years ago, our estimate was that roughly 58% of people who have a lifetime substance use disorder will eventually recover. And that's one of those statistics you can read as glass half empty or glass half full. It basically means 42% of people die addicted. But people are more than likely to achieve stable recovery, which would mean 5 years of continuous ongoing abstinence. And the figures are now slightly more optimistic and encouraging. So I was at a conference last week where Professor John Kelly, who leads the Recovery Research Institute, estimated the figures are now around 62%. So we start with about 2/3 of people will eventually achieve stable recovery, and that's good. But it's not good enough. And it's not good enough, and one of the big challenges we have is how do we push that figure higher? And my own area of work and expertise is about recovery capital. In other words, what do we know that helps people to support and sustain that journey? I'm going to say a bit more about that. But I wanted to start by saying something about what do we mean by evidence. Because it's a complex issue. It's rarely uncontested, and there are some highly debatable, controversial issues about what works in the addictions field, and the treatment field, and the recovery field. And Anne-Marie asked me earlier to say something about what do we know about residential rehabilitation. And I'm really glad to say the Scottish Government is reviewing this and looking to invest significantly in residential rehabilitation. But apparently there's a debate. Does residential rehab work? And to me, this is a completely spurious and fake debate. It's not a magic bullet. It's not a solution. But I've been involved in 4 separate projects or studies about rehab. So in Scotland, I was involved in the evaluation of LEAP, a quasi-residential rehab in Edinburgh. Clear, unequivocal evidence of benefit. I was involved, albeit peripherally, in the English National Treatment Outcome Research study undertaken at the Maudsley in the 90s. Residential rehab clearly was the most effective evidence programme included in that process. If you look at the Australian Treatment Outcome Study, the 13-year outcomes, the best outcomes were for people who had rehab at some point in their recovery journey. And our own patient pathway study in Western Australia and Victoria clearly showed that residential rehab was the single most effective treatment intervention. So where's the debate? The debate is about how you deliver it, not whether you deliver it, and what you deliver afterwards. Because one of the things we know most about recovery is it's not a specialist treatment delivery. All the stuff that comes from specialist treatment gets people to the starting point of a recovery journey. Recovery is a big switch, scientifically and academically, it's a switch from clinic-based, professionally delivered, deficit-managing approaches to community-based, peer-delivered, strengths-based approaches that are between partners. Not between experts and patients, between partners in a journey of transformation. And this is just crucial for how we understand what recovery is as a process. We typically think that recovery takes about 5 years. Why do we think this? Because the first year after you detox, the likelihood you're going to relapse is between 50 and 70%. It gradually reduces, and at 5 years of continuous sobriety, it's about 14% the chance of you relapsing. And that's pretty much the general public, general population rate. So there's a 5-year journey. What do people need to get to that point? The single biggest thing they need is recovery supportive peers and communities that enable change. And I said that my area of work is around recovery capital. And what do we mean by that? That over the course of that 5-year journey, the person needs to develop a series of resources and inner strengths, resilience, coping, self-esteem, self-efficacy, good communication skills. How do they develop those things? They develop those things through social support networks, primarily other people with recovery experience, and they deliver it through structured support. And I'm pleased to see my colleagues here from Jobs, Friends and Houses, because fundamentally those are the 3 most important things. Jobs, friends and houses. Not methadone, not Suboxone, not Sublocade. Jobs, friends and houses. Now I'm not going to get into the debate of harm reduction versus recovery and all that kind of thing, because we know that on average, the average duration of an addiction career, including that 5 years, is about 28 years. So there is plenty of time for harm reduction interventions, recovery intervention, and crucially, all those things that have been neglected, that after people have started that peer process, recovery housing, recovery communities, recovery support groups. And one of the things Anne-Marie asked me to talk about was, what do we know about peers? Well, I've done studies in both Scotland and the UK, and in America which show the same things. The 2 biggest predictors of well-being in recovery are having more social networks involving other people in recovery and more meaningful activity. The enemy of recovery is not harm reduction, the enemy of recovery is daytime television. Bluntly, and I apologise for this language in the church, my apologies. Our Glasgow study and then a follow-up in Florida, we both refer to both as Goya studies, after the Spanish painter Francisco Goya. And why? Because here and in Florida, where people surround themselves by peers with lived experience, from whom they get social learning and social control, they learn and observe how to do recovery, how to be in recovery. And they use that to engage in a whole range of diverse, meaningful activities. What does that process mean? It means you develop self-esteem and self-efficacy by achieving things, by belonging to groups you're proud of. Why Goya? Well, Goya is an incredibly complex scientific term that stands for get off your arse. The more you do, the better you do. And that's crucial, because my own academic hero is a guy called John Braithwaite. And John Braithwaite is an expert in what's called reintegrative shaming. And essentially what he argues is that recovery capital, like social capital, human capital, and restorative capital, they're all different from financial capital. As sadly all of us know, if you have financial capital and you spend it, there is less of it afterwards. Sad but true experience that bank accounts tend to tell you. Recovery capital isn't like that. The more of it you have and the more of it you use, the more of it is generated. And one of the things we know about recovery capital is, as communities develop recovery groups and recovery networks, it has positive impacts that ripple out. Because the other big difference between recovery science and addiction science is the individual stops being the unit of analysis. We don't think of a diseased body to be fixed or cured. We think of individuals who actively contribute and make their families better, their neighbourhoods better, and their communities better. And in both the studies we've done, we called this the better than well phenomenon. So, 2 examples. First one, when we did our Life in Recovery survey in the UK, we found that the rate of volunteering, active contribution to your community in the general public is 39%. Among people in stable recovery, it is 79%. Twice as likely to be active agents in the well-being of your community. The second thing is, we did a quality of life study about 10 or 12 years ago, where we found that people in long-term recovery had better social recovery capital, better social well-being, and better environmental quality of life than people who'd never been addicted in the first place. Why? Because they are more actively and strongly involved in the social networks they belong to. They contribute and give. The thing we know about crime reduction is the single biggest predictor in a neighbourhood of low crime rates is what we call collective efficacy, also known as trust. The more active community engagement there is in communities, the lower the risk of crime. The more people in long-term recovery there is in a community, the more visible recovery is, the more active communities are, and the more actively engaged and well those communities are. So it's selfish to want investment in recovery. It's selfish to want your next door neighbour to be somebody in recovery, because they are more likely than the average person to contribute. And there is a dynamic. One of the things we know about recovery capital and why it's a million miles away from the disease of addiction or the study of addiction or pharmacotherapies or talking therapies is because it's not about the individual. It's about the dynamic process of giving people the scaffolding they need to get better and then giving back to the communities they live in. And just to give you an example, there's not that many randomised controlled trials, and I promise I will quote some science for Anne-Marie's benefit. She asked me to do science, so I'll do science. A guy called Mark Litt in the States took 160 conditions. Half of them got standard aftercare, half of them got what was known as network support. Basically that meant, could you add one clean and sober person to their social network? If you add one clean and sober person to somebody's social network, their likelihood of relapse in the next year went down by 27%. That's about 3 times the effect size you get for relapse prevention as a talking therapy. This is the social contagion of recovery. And virtually all of those people were recruited from Alcoholics Anonymous, their friends and helpers. It's socially contagious. In both an American study by Longabout and a study that I did in London, we found that the biggest predictor of how people sustained recovery was how strongly they were involved in 1, social networks of other people in recovery, and 2, actively involved in their communities. This sense of participation is crucial. And ever since 1965 with somebody called Reisman, we have known what's called the helper principle in science. If I help Dougie may or may not benefit from that help, but I benefit from the increase in self-esteem, self-efficacy, and sense of purpose and belonging I have. And it's one of the miracles of the 12th step is the 12th step, the giving back. It sustains the organisation, but crucially, it creates that collective efficacy and community capital that is just crucial. And this isn't meant to be a talk that criticises what treatment services do, because they get people to the starting line of recovery. It's about what should be beyond that. And I've been involved in setting something up called the College of Lived Experience Recovery Organisations. And one of the things that we ask for, and we've requested in this, is what's called parity of esteem. Not that recovery organisations get the crumbs from the table and the tiny little bits of additional funding when there's underspend, but that they are treated every bit the same and with every bit as much respect as the NHS and specialist treatment services. Why? Why should that happen? And incidentally, in America, since in the last year or so, there is now a 7% ring fence for recovery community organisations. It can't go through the American equivalents of CGL and humankind. Because there's an understanding there that if it does go down that road, we're still in crumbs from the table, and when they don't have a crisis and an underspend. This money has to be protected money. It has to be money specifically for the people who have the expertise and the knowledge in that work. Why would you do it? Well, effectively, what community recovery organisations in England they're referred to as lived experience recovery organisations, in America they're referred to as recovery community organisations, and we're just getting to the point we have an adequate science of these things. What do? Well, they basically do 6 things. 1, they act as hubs. They provide services through things like recovery clubhouses and recovery cafes, where they do things like the fabulous Favour Advocacy Project. They provide something that's kind of akin to a service. They do in-reach. So in England, to give the examples, the Well in the northwest of England, they provide in-reach into accident and emergency to people who've overdosed. They provide in-reach into prisons, HMP All Course in Liverpool. They do that because the idea there is not everybody needs specialist treatment. Engaging them with recovery navigators and recovery coaches early can spark that light of recovery hope. Third, they do outreach. So in Middlesbrough, Recovery Connections in Middlesbrough, they have a coffee bank. Their recovery ambassadors will go out into well-known using areas in Middlesbrough, and they'll say to people, do you want one of our excellent homemade coffees? All you have to do to get an excellent homemade coffee for nothing is talk to us about recovery for 10 minutes. And if you talk to us about recovery for 10 minutes, you get your coffee. This is outreach. Community building. 4, community building. Well, in Barrow and Furness and Morecambe, they have social supermarkets. So if you give them a couple of pounds every week, you'll get 20 to 30 pounds worth of fruit and vegetables. Not for people in recovery, for people in the community who lack the financial resources to eat healthily and eat well. This is that everybody who works there is in recovery, but the recipients aren't in recovery. This is about a recovery organisation serving and servicing its community. Linkages. The advocacy project at Favour is a great example of assertively linking people in to groups, resources that they need. 6, and one of the things which I think Favour does, and is done by virtually all recovery organisations, is mobilisation of community resources. And I know that Natalie and Cisco have been doing this work for a while here as well. This is about how you generate community resources to support recovery, to support the community. There's that ongoing dynamic process that recovery supports individuals, but the more individuals you get to stable recovery, the stronger the community itself becomes. This is a dynamic process of growth and change. All 6 of those functions, service delivery, in-reach, outreach, community building, assertive linkage, and community mobilisation, are things that are absolutely essential, not just to sustain individual recovery, but to make communities places where recovery can happen. And that's why government should fund recovery communities. Not because they think they're a nice adjunct to treatment or they offer free aftercare or cheap aftercare. Because this is not a linear process. This is much more akin to a donut than a line. Those resources and services constitute prevention. They constitute early intervention. They don't just constitute aftercare. The high visibility and presence of recovery champions and recovery is really appropriate that we're doing this in a church, because churches do this stuff all the time. And effectively what we are doing is borrowing that model and deploying that model. I'm going to try and avoid being particularly controversial. I am going to just say that one of the things that I find hugely frustrating about the UK's model is the continuing sense of failure. We did a workforce well-being survey, and we estimated the level of psychological health problems in drug and alcohol workers in Victoria. 1/3 of workers in Victoria had lower psychological health than the average new client in their services on the day of intake. This is a combination of burnout, stress, and perceived failure and hopelessness of their work. If we have a learned helpless task force, workforce, who are effectively propagating failure, we get care is an act of prevention as much as it's an act of aftercare. But crucially, it's an act of early intervention, where your visible, active community agents are social contagions of hope. Recovery doesn't rely on treatment or specialist delivery or recovery. It's a combination.